This is a case of 57-year-old female patient who came to our OPD just a couple of months back. This is a recent case. So the main complaint is difficulty in walking, wobbling and buckling of knee associated with pain for last 1 year. The chief complaint here is more of instability rather than pain. So she had a road traffic accident 2 years back, knee was dislocated. Fortunately, there is no neurovascular injury. So closure reduction and plaster, all this procedure has been done elsewhere, not in our place. So closure reduction and plaster application was done immediately. The plaster application was maintained for 2 months. So a two-staged multiligamentous reconstruction has been done. So which has been done, the last surgery was done approximately 11 months back. So in the first stage, ACL and PCL has been done, and the second stage, PLC and MCL has been done. So this is how she is walking when she presented to us. Very unstable knee on the right side.
Okay.
These are some examination videos.
All right, so let's, Rajesh, I'll start with you. So what are you thinking?
Well, I think that there is gross ligament instability, and it's a global instability. Although the repair was done, this is the situation, and I would keep hinge ready.
You're gonna have a hinge ready. All right, Ashok, you gonna have a.
I'd like to see the X-rays first.
Okay, but you're seeing a clinical exam.
No, I'd still want to see the X-rays.
Okay, show us the X-rays.
Range of motion, she has a hyperextension of about almost 30 degrees. Range of flexion is good. There is no stiffness.
We can see it. Yeah, okay.
This is the pre-reduction X-ray. This is immediate post-reduction. So these are the standing X-rays.
All right, so Ashok, you're up.
Hinge.
Hinge, okay.
I think if there is no neurological issue here, it's just a post-traumatic, 90% you can even do with the primary PS knee. If you balance it very well, you have to just take the less femoral cut. We may have to upsize the femur to fill your flexion gap. And you have to keep constraint design, of course, standby. But my prediction is probably you can do it just with the primary
PS, okay.
PS implant.
Arun, anything to add?
Probably a fixed hinge.
Fixed hinge, all right. Dr. Mohanty?
I agree with Harish that if the MCL is competent enough, then I would go ahead with a PS knee only. But I keep constant is standby on the table.
Dr. Berry, anything to add?
Not really. I mean, this lady, the way she walks scares the heck out of me. And I think that even if she's on the borderline of maybe being okay with something less constrained, I'm thinking about a hinge here.
Yeah. Thorsten, you're doing a hinge?
My answer is quite clear, but the gait showed probably some kind of neurological disorder, I don't know. And then we are on the same discussion as we had before.
Okay.
So I agree with Arun, fixed hinge, that's why he said fixed hinge.
Yeah, I mean, my take-home point would be I don't have a problem starting off trying to put in a knee, but at the very least, I would have a constrained knee. I wouldn't put a PS in, even if I thought at the time it was stable.
At a minimum.
Yeah.
Somebody like this who's already demonstrated they keep loosening up, things going worse, going bad, unstable.
Right.
Go a little overboard on the
Yeah.
constraint, not underboard.
I agree with that. All right, tell us what happened.
So this is the immediate post-op X-ray. This is the TC3 semi-constrained. You had to use the distal femoral augments because even with the minimal cut, the knee is going into hyperextension. So had used distal femoral augments.
Okay, so let's he distalized, right, the femur. He's got a stem on the tibia. Anybody have any comments or criticisms?
He has taken, I think, a big tibial cut. You can see the base plate is touching, almost going below the tip of the fibula there. So that big tibial cut probably will mean that you may not be able to fill the gap, which is there. And then you may have to use a big insert and maybe constraint design. So you have to also be very prudent on the tibial side. You should take very little cut so you get adequate space to play with.
I agree with that. Anybody else? You didn't use a femoral stem.
I should have used, I don't have a good answer to defend, but I thought there is no bone loss. So the bone stock is good enough to support the femur is what I thought, but should have used it.
Yeah, but you put in a constrained knee, and I think just like we were talking about being sort of over overly cautious with the constraint, you should probably be overly cautious with the fixation as well, right?
Especially in bad bone, right?
Yeah.
The only other thing I would just say is that you can see some asymmetry of the medial and lateral side here in terms
Yeah.
of the joint space, which means that even with a TC3, there's still some residual instability, which makes me a little anxious.
100%. All the more reason to put a stem on the femoral side because there's that post can't do all the work. So it's going to transfer a lot through the femur. You know, and I think the point I want to make is we spent all day talking about alignment, right? It's fixation, right? Cement technique. That is the most important thing. If you screw that up, it doesn't matter what robot you used, right? So focus always on, and don't minimize your fixation. So show us what happened.
So intraoperatively, it was stable. So this is 1 month post-op X-ray.
Well, let's go back. When you say intraoperatively it was stable, are you checking that with the TC3 trial or?
So that's with the trial.
Okay, so here's one of my pet peeves. Whenever I do revisions, I don't want to use the constrained trial to check my stability. Of course the knee is going to be stable, right? You want to put a PS insert trial in, right? So I'll put a PS insert trial in and check my stability, and if I'm happy with that, then I'll put the real constrained insert in. Are you following me? You don't want to trial it, you know, doing this with a constrained insert in gives you no information.
Makes sense here. So this is 1 month post-op video which the patient has sent.
Looks like she has a little residual valgus in her knee.
Do you really think she's stable? I mean, if you go back to the X-ray, you see a quite big gap on the medial side, and on the first X-ray there was a gap on the lateral side. I mean, even a CCK like this has limitations, and I don't think, if you look at the X-ray, there is a big gap in the medial side, and if you see her walking, that's not a normal walk. She still tries to compensate her instability.
But again, the same point, she's walking on that block of plastic post. She's walking on that.
All right, well, you got her walking. You have anything else to add?
I think not much of papers that has been published on this after TKA after a multi-ligament surgery, but whatever the published from the Mayo Clinic, there is increased risk of revision, reoperation, and implant constraint. This is what the major paper that I have found in literature. But I want to ask the panel, how many of you would consider a primary total knee replacement in an elderly patient coming with a multi-ligamentous knee injury?
I think that we made the point, though, if you're going to do a knee replacement, you probably should have, at the very least, a constrained knee in a multi-ligamentous, prior injury. All right, so you did the right thing in that regard. Your alignment could have been a little better. Your balance could have been a little better. You could have had a stem up of the femur, but so far, so good.
Amar, I don't think you can balance that knee. You're just either going to have to depend on the poly or a hinge. There's no question of doing soft tissue releases and balances because the quality of the tissues is so pathetic. You can't really balance it.
No, I mean, but that's the decision that you have to make intraoperatively and then decide to go to the hinge, right? All you can do is assume that he made the, correct assessment and that the MCL was strong enough to support, right? But yeah, I mean, I think I agree that the story of this knee is not over. All right? All right.